Thank you very much. Good afternoon, everybody. Sadly, it is true. I am officially the only person in the House of Commons who is a shadow of his former self, but working on rectifying that next May. Early next year, in January, I'm going to set out a 10-year plan for the NHS and social care, a 10-year journey towards the full integration of health and social care. And what I want to do in speaking to you this afternoon is give you a sneak preview of what will be in that plan. For those of you who are NHS colleagues in the audience, I know what you're thinking. Oh God, here comes another reorganisation. I've spoken before in this city when my speeches has ended in a round of booing and heckling, so I'm kind of hoping that to avoid that today and hoping to reassure you that we can do the change that we need to do without a reorganisation, and I'll come on to that. But I suppose the first thing to say at the beginning is, what is the problem as I see it, and what is the solution? And then I'll take those two issues in turn as two halves of my speech. Firstly, the problem. As I see it now, we are at the very limits of a 20th century model of care. And what I mean by that is a medical model or a treatment model that's based around the hospital. That is my analysis of the problem that we have. And my solution is to move from that medical model based around the hospital to a preventative, more social model of care that starts in the home. That, I think, is what we've got to move towards if we're going to rise to the very enormous challenges that the 21st century presents in terms of ageing and the change in lifestyle. So I'll take each of those things in turn. Why do I say that we're at the very limits of this 20th century model? Well, I think you need only to visit any acute hospital in England right now, and you will see the evidence of that. What we have in England right now is a record number of people, and consequently a record amount of money trapped in the acute hospital. And that's because we've allowed a situation to develop over many years and over many governments, let me make that clear, where we've deprioritised social care, underinvested in it, and basically allowed a situation where the hospital becomes the last resort. And indeed, we've even kind of cemented that in place because that's how the NHS gets paid, by activity, by the number of people coming through the door. And I believe it just simply is just isn't sustainable. And in the course of this Parliament, I think it's reached breaking point. I warned the current government at the very start of this Parliament that on the current plans that they had for public spending, it would be irresponsible to give the NHS all the money, real terms increases as they claimed they were going to give it back then, if the way they were going to pay for that was by raiding local government and particularly social care. Now, the Prime Minister quotes those words every week, but he never quotes the full amount of what I said. He just says the irresponsible part. He never actually goes on to say what I said about social care. But I think that warning has been borne out in the course of this Parliament. We've seen home care support removed from around 250,000 vulnerable people in England as the financial situation facing local government has deteriorated. They have had to cut back eligibility to social care. Now, the problem with that is that social care is prevention. It's the preventative part of care. It's the simple help with living your life, with getting up and about, washed, dressed, doing the things that you want to do. But we've been cutting that and cutting it hard. And what it is resulting in is people not coping at home and then the drag towards the hospital, and people then getting trapped in the hospital. I was in Wigan Infirmary last weekend, and they were telling me that right now they are facing the unprecedented pressure. Another hospital in the south of England said that last week was the worst week that they had ever experienced in terms of the volume of people coming through A&E, but particularly the number of emergency admissions of very frail, very elderly people. You know, look no further than this statistic if you want proof of a system that is now in serious distress. Hospital A&Es in England have now missed this government's lowered A&E target for 73 weeks in a row. Now, what does that tell us? A&E is the barometer of the whole health and care system. It's the classic barometer. If there's a problem anywhere in the health and care system, as you will all know, in the end, it is evident in pressure in A&E. If people can't get GP appointments, you will see increased attendance at A&E, but particularly if people can't be discharged home from the ward in a timely manner, then the hospital starts to become dysfunctional. So the wards become full, and then A&E can't admit to the ward. So A&E becomes full, and therefore the ambulance service can't hand over patients to A&E, and they start queuing outside. And that's what's happening right now. We're seeing pressure backing up through this system, through A&E, having a knock-on effect on the ambulance service and other hospital services. And it can't carry on. I cannot see how we can possibly carry on running this model and expecting it to work. It's not working for people, because when I was in Wigan, the lengths of stay that some people are experiencing on the ward are just they're not right. I mean, we're talking of people trapped in hospital for 90 days or more, and that's not uncommon now around the country. If you ask a trust chief executive, they will typically say at any given moment around a quarter or a third of the hospital is medically fit to go home. The patients are medically fit to go home, but can't be because nursing home placements can't be arranged or home care can't be provided. Now, that's not sustainable for those people, but it's not sustainable financially either. The acute hospital is the most expensive end of the whole health and care system. And you can't have a situation where we're saying that people are allowed to drift towards the hospital and then become stuck there. It won't work. It won't work on any level. And it was interesting actually speaking to staff last week how they describe the continuing collapse of social care now getting to the point where it is in danger of dragging down the NHS. They were describing how a CQC inspection recently of one of the local care homes had resulted in part of a home being closed and 50 or so EMI beds being withdrawn from the local health economy. That has a devastating impact on then the hospital's ability to move people through. And it cannot be right, can it, that the NHS is kind of beholden to the whims of the private social care market, unable to be the master of its own destiny. That is what's happening to the acute hospital right now. It's not the master of its own destiny. It's beholden to the actions of others around it. And I think it's getting to an increasingly untenable position for the staff working within the hospital, but also for the finances of the whole health and care system. And you see another example in the news this week, another example, I would say, of how this system now is gone beyond what is acceptable. I don't know if you saw it, but it was about a care home in Surrey that had been investigated by the CQC. They had deemed it to be unsafe, and we had hundreds, I think around about 100, very frail elderly people being moved out of the care home late into one evening this week, about 11 o'clock at night. I mean, what's going on? I mean, that cannot possibly be something that we can say is acceptable in the 21st century, that a huge number of very frail, very elderly people are being moved and shunted around the system at all hours of the night. I mean, this is wrong. And basically it comes down to the point that social care has been neglected for far too long, and it can't carry on, because if it carries on, in the end, it will drag down the NHS with it. So you're thinking, well, when's he going to get onto the solution? So here's the solution. Here's what I propose to do. I will set out in January a plan for the full integration of health and social care. Now, when I say that, I'm not talking about integration as perhaps we've tried to do it before with pooled budgets or joint appointments, the kind of ways of trying to scale that Berlin Wall between the NHS and the council and make things work just a bit better. I think we've got to embrace something much more radical, and that is the idea of a single budget, a single service, an NHS for the whole person, if you like, or another way of putting it, a national health and care service. If you go back to the time when the NHS was set up, the World Health Organization set out its definition of health, and it's a definition that still stands today. Health is, quotes, a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Complete physical, mental, and social well-being. It's a wonderful vision, powerful vision. But love the NHS as I do, it's never been set up to deliver it because of the exclusion of the social part of care and the tradition that we've had that councils do that part of care and the NHS does the rest. Well, I don't think that can carry on. We can't carry on saying to the public, oh, if your mum or dad needs support, ring the council for this bit and the NHS for that. I don't think we can carry on disaggregating people into these public service silos. If you think about it, physical, mental, social, we try and meet those different elements of one person's needs through 3 separate delivery systems. So people's physical needs are done through the mainstream acute NHS and primary care. People's mental needs are done through separate organisations in separate buildings on the fringes of the NHS. And then their social needs, separate again, outside of the NHS, means tested, done by councils. Well, I just don't think, as we're all ageing and living longer, that's not going to work, is it? If you get to your late 80s or early 90s, you can't disaggregate one person into the physical bit there, your mental bit there, and your needs become a blur of all 3 at that point. And that's why, for me, it points to truly integrated care that is about one team around the person, starting in their own home. So that is what I will set out a plan to move towards, commissioning with a single budget at local level under the Health and Wellbeing Board, a combination of the NHS budget and the council care budget. And from there, we'll do something, I think, truly radical, and that is develop a different way of paying for care. And I'm going to set out a plan for a year of care budget rather than the activity, to replace the activity tariff, particularly when it comes to the care of vulnerable people. So if you think about that for a moment, a year of care budget, that for an individual identified as having ongoing needs, assessed by the council as needing support with their needing social care support, it would mean a single payment comprising physical, mental and social care, also their primary care too. And the reason why that I think is so important is because it would finally give the system an incentive, a true incentive for prevention. It would ask people to support people where they want to be in their own homes. That will be the logic of a system of that kind, not a system that's paid by failure, paying for people coming through the door. It would turn the financial tide around, that tide that currently drags people or sweeps people towards the acute hospital. It would turn it back the other way and put a premium on supporting people properly in their own homes, which is where they should be, with a combination of support, a single team based around them, comprising their physical, mental and social support. Now, that for me is best for people, but it also is the only way we're going to make this whole system financially sustainable in the 21st century. And I think what it points to is a fundamental rethink of the way we provide care. I don't think it is acceptable, to be honest with you, that any very frail person should be asked to leave their home or their care home to be shunted into a busy A&E or a noisy ward and moved around the system like that, like a commodity. I think we should have the clear expectation that the home and not the hospital is the default setting for care in the 21st century. People should, if they can, be supported there, and we should build in all of the support around them to achieve that. And yes, that might mean new opportunities for telecare and some of the organisations that are here today. I think finally we might have an incentive to invest in that kind of home-based preventative support, and for me that can only be a good thing. So that is what we're going to do. Further from just integrating care, we will repeal the Coalition's Health and Social Care Act 2012. Why? Because I've come to a very clear conclusion. The market doesn't get you to the care model that I'm describing to you today. If you follow the logical consequence of a system based on any qualified provider and mandatory tendering of services, as has been happening for quite a long time, you end up with an ever-increasing number of providers on the pitch dealing with one person. You end up with ever-increasing fragmentation of care. You intensify the frustration that the public already feel in telling the same story to everybody who comes through the door, and nobody puts the whole picture together. It does deliver fragmentation when the future demands the opposite, integration. So that is why we'll repeal that act. But as I said at the beginning, there won't be a reorganisation, because unlike Andrew Lansley, I will work with the organisations that I inherit. And I will work principally with the Health and Wellbeing Board, because as with anything, when things change, there is always some good that comes from it. And I think that was a positive development. The notion of an entity at local level that brings the council and the NHS together and is a partnership body by definition. In my system, that is what I will work with. The definition for me of a reorganisation is when you dismantle a whole set of organisations and make people reapply for their jobs. So we're not going to do that. We will ask the CCG to work to the Health and Wellbeing Board so that it can develop an overarching plan for population health. And to be honest, this takes you to local government and the future of local government, because I think the policy I'm describing is as much a future for councils in England as it is about a future for the NHS. Why is it so important to work through the Health and Wellbeing Board? It's so important because finally it would give us the opportunity to link health policy to the wider determinants of health at local level. So, for instance, finally, we would have the ability to link health with housing policy at local level. Now, just think about that. If we really had proper alignment between those two policies in every community, I think we could really begin to come up with solutions that are ready, that are right for the 21st century. When the great Nye Bevan set up the NHS, he was Minister of State for Housing and Health. And people have forgotten that. Somewhere along the line, well, it was in the 50s to be honest, the NHS broke, that link was broken, and the NHS became ever more medicalised and specialised. And I think you've got to get that back if you're going to rise to 21st century challenges. So rather than just building 5,000 homes here and 10,000 homes there, we need to be building homes in every community as places where care will be delivered in the 21st century. And then we need to be commissioning services to go into those homes to support people there. And that is why this model going through the Health and Wellbeing Board is so important. But it's not just housing. You can link health policy to leisure policy, to planning policy, to education policy. You can support children with complex needs very differently, because the whole person approach applies as much to the start of life as it does to the end of life. It's about commissioning for all of one person's needs, be that a child with complex needs, an adult with learning disabilities, or a frail elderly person. So I think you can see where I'm going. The vision I'm putting to you here is the Michael Marmot vision of health in all policies. Health in all policies at a local level, commissioning for the well-being of the local population. And for me, that has to be the 21st century vision. Take away these arbitrary rules that are stopping hospitals moving to make partnerships with GP practices, with social care providers. Let's just let the system get on and integrate and merge and partner so it can build integrated care organisations that can deliver the model of care that I'm describing. And finally, let's do something else that's really important here. Let's ask the NHS to pick up social care, because currently that system is just broken, it's on the floor. And it's never, in my view, it's never, ever going to provide the standard of care that you will want for your parents, I certainly want for mine, and indeed, as a society, we should aspire to for everybody's parents. We can't keep running this thing that we protect the NHS, but we let social care go to rack and ruin. It's gone. For me, that thinking has just got to go. And I want to see the NHS, the strength that we have in NHS workforce planning, in training, I want that applied to social care. I want the NHS to put its hand underneath social care and begin to lift it up from the broken system that we've got today to one that is about quality and values the people that work in it. You know, it is completely indefensible that 6 out of 10 people working today in the care system in England are on 0 hours contracts. Indefensible. How can somebody who doesn't have basic security over what they're going to earn from one week to the next ever be able to pass on a sense of security to the vulnerable people in their care? It's just not going to happen, is it? And how can it be right that we're running a system here where we're not even paying people the minimum wage because they don't get the travel time between their these flying 15-minute visits that are being commissioned? How much longer as a society can we carry on sending out the message that social care is the lowest form of work, lower than the minimum wage because you don't get paid properly? Well, it can't carry on, can it? And I think we've got to now resolve to make a big change. So this is the vision that I'm building up. The party that created the NHS in the last century is ready to reset the NHS for the 21st century. Reset it as a whole person service where social care comes in, where we can begin truly to personalise care for people, starting in their own homes, where we can give people powerful rights to get the kind of care that they want. The right to a single point of contact for the coordination of all of their care. Imagine what a huge step forward that would be. The right to a personalised care plan, the right to give birth in your own home, or fundamentally, the right to be in your own home at the end of your life. That is the illustration at the end of the day, isn't it, of a person moving from a patient-centred model that we've got today, where far too many people end their lives in hospitals, to a person-centred model, where you support people where they want to be, surrounded by the people that they love. So that's the vision. That's what we're trying to do. It is bold, it is big, but that's why we're saying it's got to be a 10-year journey. Each locality will have to embrace its own journey towards full integration. And it won't be the case that we should dictate to people about how it should be done. We should devolve that responsibility to local level. But I am clear now that we are at the limits of this system. The NHS does need to be fundamentally reset, and that the party that created it is now ready to do just that. Thank you very much for listening. Let's take questions.
Well, thank you, Andy. Terrific vision, very clear, very compelling. Thank you very much indeed. I think you're prepared to take a few questions,
Sure,
a bit of time?
Yep.
Excellent, thank you. So, Tony.
Thank you very much. I couldn't agree more with your diagnosis. I couldn't agree more with your solution. But as a non-exec director of an acute trust, if this is going to take 10 years, what are you going to do to help the acute trust sector over those 10 years?
Okay. Shall I take them one by one?
Yeah.
Well, I agree. I mean, I began by saying that I recognise how serious the situation is. More and more people in hospital means more and more staff needed, the agency bill going up and up. You know, that we're trapped. I think the acute sector is trapped in a downward spiral at the moment, and it urgently needs to break out of that. And that's why my vision is around saying, or I think this is the right way to go, asking the acute trust to become an integrated care organisation, to evolve into an integrated provider, working from home to hospital, covering the full spectrum of need, physical, mental and social. Now, it doesn't mean that the trust has to do it all of itself, but to use the Americanism, I think it should be the accountable provider, the organisation on the spot to improve, to coordinate that care journey. Because coming out of my visit last week to Wigan, I think the acute trust, if it's going to make things work in this century, it needs more control over every stage of the journey. It needs to be able to move people through more quickly to where they need to be. And it can't do that when it's always dependent on others. So that's the vision. And I see my preferred way would be that the year of care tariff that I described, or the year of care budget, would be paid to the acute trust. And I think that will give it the financial stability, rather than being dependent on the whims of the activity tariff, to start to put down roots in the community, to build out and to remodel fundamentally what it does. Now, I appreciate doing that while dealing with the pressures that you're under is difficult, but the two things are linked together, aren't they? I mean, I'll just give you a very simple example. I mean, to give you a flavour of where this is going. Salford Royal, I mean, they get a lot of praise, but rightly so, because they're very innovative and they're doing some great things. They came up with they had a problem with emergency admissions from care homes through their A&E, and this is another illustration of the issue I was describing. Basically, I think you'll recognise the situation: untrained staff left late at night in the care home, something happens, 999. That's what, you know, don't blame the staff because they're not properly supported, but that's what they do. So Salford Royal got hold of that and took on board a GP practice just to deal with the care homes. So if any calls were coming from care homes now, they were told not to ring 999, but ring this dedicated GP practice. And they cut emergency admissions by a huge number immediately, in fact, and made savings in year, straight away, hundreds of thousands of pounds. And for me, the savings of integration are not mythical. They're not like kind of promised savings that politicians talk about that never actually materialise. I think they're there. They really are there if we allow people to remodel themselves to grab them. And we've got a situation in Salford now where, to kind of show you that this is where thinking is already going, Salford City Council are about to commission Salford Royal for their social care from next year. And this is, you can see, can't you, this leap into a different way of working. You know, why should a council commission 2 Bob home care companies on these 15-minute visits, not training their staff? Because those 15-minute visits aren't keeping people out of hospital because they're so slapdash, they're not working. So it immediately says to me that it makes more sense for councils to start working through the NHS, to start commissioning whole person care via their trusted local NHS partners. It makes complete sense to me. You'll get more for public money if we do that. So, long answer, but it's a very important question. I know it's hard right now, but I want to give you a route map to a future, something that you can say, right, we can see where this is going, and the stability to deliver it, and yes, some extra money, because we've committed to a mansions tax to bring in some extra funds into the NHS over and above what this current government are proposing to begin this process of change.
Questions, please. Yes, this lady here.
you planning to underpin all this with equipping staff, agencies, organisations with the skill sets and change of attitudes to do all of this? You know, people who work in the NHS for years and years, or in related areas, for years and years we've all said about we need an integrated system. You know, so it's good that politics have caught up with this. You know, so how do you underpin it? Because unless people change attitudes from the top to the bottom, from the bottom to the top, how do you do it?
Yeah, well, that's a good question, and you're right. People have talked the talk about integration, haven't they, for a long time, and it's never been a reality. So I agree with you. I think you put your question in a very forthright but fair way. So how do we do that? Well, I think the one thing we don't do is me start mandating to the staff saying, oh, you must do it like this, because that was sometimes the style of the last government, and I'm not going to repeat that. You know, the idea that here's what we want you to do and here's how you're going to do it. Personally, I think we've got to devolve the how. It's my job as a national politician to say, here's the what. You know, here's what every person in England should get from an integrated national health service, both in terms of the treatment standards, the medication. And here's what we should pay the staff in a national system. Here's what we can afford to do in terms of locating complex services. So my job is the what, and I think we need to do that more than we currently do, because there's still too much postcode lottery in the system. But then what's the local job? For me, the local job is the how. How are we going to deliver that entitlement in our community? And I think politicians at national level really have to let go of that and really trust people at local level to devise their way to get there. We should be uncompromising about what it is. You know, the person in their own home, supported by a single team, one person to ring if the family has a problem, a personalised care plan agreed with the family. I can tell you what the what is, but I am going to trust people to say, you do it. It's going to be different in Salford than it is from Liverpool, than it is in Torbay. But that's the thing, isn't it? Areas are already doing it. That's why this reform has got a chance. Lansley was trying to force the system to go somewhere it didn't want to go, but I'm going with the grain, aren't I? I'm not telling anybody here anything probably they don't know already. I just want to free you up to do it. Take away that contracting stuff and all that marketisation, all of that. Just let people get on and integrate and partner and build these integrated care approaches. So, you know, that hopefully answers your question. Obviously, there's going to need to be support along the way from the Royal Colleges and others. But already the Royal College of Physicians have issued a report called The Future Hospital, and I would definitely recommend it to everybody here. It is as close to a blueprint for what I'm describing as I think we've seen come out of the professions. You know, the idea that professionals need to abandon their loyalties to parts of the system as we've got at the moment, where GPs are loyal to primary care and they fear a hospital takeover, and the hospital thinks GPs don't do their job properly, and mental health is somewhere else, and they're always moaning about physical health taking all the money. That's not going to work. Everyone's got to come out of these silos and start looking at the public as their focus and building out from there. So it's not easy. I take your point. It's a journey. That's why I'm calling it a journey, because it can't be done overnight. Let's give people the time and the space to embrace this culture change.
One more question, is that right? Maurice, you wanted a quick one? Yep. Okay, and that's about it, Liz, do you think?
Thank you very much. I absolutely support, I think, the diagnosis and part of the solution. I would say, though, I do have some considerable anxiety, and I do speak as a GP, regarding the solution of the hospital will be the accountable organisation and will be responsible for overseeing the system, and how that actually relates to the Health and Wellbeing Board, because that doesn't appear to be, to me, how it works currently, and clearly working forward a 10-year journey, it may not be how it works in the future. But given that trusts are in deficit all over the country, then what's the incentive to actually invest in services for them? There is a hard truth somewhere in the system, which is, in order to save money somewhere, something has to close. And if we're going to save money in hospitals, then some part of that system has to close. And that's a very mature conversation about how do we redeploy those staff, how do we get them into community, how do we get them working in those integrated care teams that I absolutely passionately support. And I do think that we just need to have some consideration to perhaps law of unforeseen consequences in taking that type of policy forward.
Well, thank you. That's a important question and a good one on which to end. Well, the first thing I would say is I am truly going to devolve the how. My preference, the best solution I think that will work and unlock money more quickly would be a solution where the hospital embraces this and grows into a very different entity. Because let's remember, as I've said a couple of times today, the money and the people are trapped in the hospital. And if the solution doesn't embrace how they work and think and what they do, I think health economies might still struggle to find a path towards viability if there isn't something that is very much intrinsically based and agreed with the acute sector. But having said that, I mean what I say. I'm genuinely open-minded that different models of care may evolve in different places. In some places, it may be more GP and community-led. I mean, I'm genuinely open-minded about that. Or I can very much see a situation where the acute trust doesn't employ everybody, but it works in partnership with trusted practices, other organisations to start to rethink and remodel what it does. But then that comes down to that question about what confidence can we have that the hospital will do it when they're facing all of these financial pressures. Well, that then flows from the logic of year of care, doesn't it? If you think through the logic of a year of care budget, because immediately, if you were to create a year of care budget for somebody assessed as critical or substantial in respect of their social care and who is spending time in an acute hospital at the moment, you would create a different incentive about that person. At the moment, the incentive is to let that person drift towards the hospital. And what a year of care would do would say, it's going to be better for everybody if we support that person properly in their own home. You know, it's the simple, spend a few pounds on simple support in their own home rather than thousands of pounds keeping that person in an acute hospital bed. Because if we fail and they are spending too long in a hospital bed, the year of care won't be enough to cover their care and we'll have a financial problem. So the system is being refocused basically on the home, on the community, and that is the logic of the financial incentive that's being created here. So rather than hospital takeover, the argument is a very different one. It's about hospital really remodeling and really rethinking what you are doing and switching resource from where it currently is to the home and to the community. And yes, you're right. You are absolutely right. That requires a degree of honesty and maturity in how we put that debate over to the public. And I'm going to do that because the logical consequence of what I'm describing is that there will need to be less money spent in hospitals and there will be a need for fewer hospital beds. If what I'm saying is to be a success, then I absolutely embrace that. And that is exactly what happened in places like Torbay when they embraced this model in the middle of the last decade. They say to me that they were able to close around 200 general medical beds. And that's the point, isn't it? It's not the A&E that will have to close or the maternity unit that has to close, because those are the things that the public value most. It's those beds that are the holding ground for older people for whom there is nowhere else to go. Those are the beds that will have to be, that should be rightly freed up and reduced. Because, as Torbay said, they didn't have people marching in the streets to save general medical wards. You know, they bought the idea that you can put forward a better, more humane, more progressive model of care for older people. So I will very clearly set that out. I will say, if we win the election, that the NHS is being reset as a social, preventative, home-based system. But that might, so you can expect big changes. So one point of contact, a more personalised care plan, but expect your hospital to change. I mean, the biggest endorsement of Torbay that I could give is that when I went there to hear about their model, they had a PowerPoint presentation that I was shown, and one of the bullet points on it had more people in Torbay die in their own home than anywhere else in England. And this issue matters to me a lot for personal reasons, and I leapt on it and said, oh, that's interesting. And being a typical politician, I said, oh, did you set a target for that? And the chief executive said, no, we didn't actually. He said, we were surprised to find ourselves at that top of that table, but it's what naturally happened when we built a system based around people in their homes. And that, for me, was like a real penny drop moment. You know, that is what we should be aspiring to, isn't it? Person-centered care. And I think that's probably got the moment is we've got a patient-centered mentality, i.e. we'll treat you in a hospital, we won't treat you where you want to be. So, you know, I do take on board your point. I'm open-minded about how people will make this journey and the different models of provision that might exist in different communities by the end. Sorry, I know I'm probably going over. One thing to add, I think it does require a very big shift of mentality to the one that we've had in this Parliament, but it also under the government of which I was a member. And that mentality was, when foundation trusts were created, that it was all about individual entities and thinking about the viability of the individual entity, and that as then a competitive player in a marketplace. I have thought deeply about all of this, and I've come to the conclusion that approach won't work in the long run. There's good benefits that come with foundation trust status, and you would keep that. But the challenge now with public spending as it is shouldn't be about the viability of individual institutions. It's going to have to be about the viability of whole health systems and whole health economies. And Monitor, in my view, is going to have to change its focus from assessing individual pieces of the jigsaw to starting to help people broker organisational and financial solutions that sustain the whole of the health economy. You know, it doesn't make any sense, does it, for Monitor to say, well, to a trust, here's how you get to FT status. It's if all they're doing to do that is hoovering out the money out of all of the organisations around them. I mean, that is not going to work, is it? So, big changes in terms of the way we've been thinking, and I don't shy away from the honesty and the kind of maturity that you were calling for. And in fact, you know, what I would do is set that out very clearly to people at the start of this 10-year journey next year.